Hi, I'm Laurie Rachet Jacquet. I'm a PhD student at the Center for Health Economics in York, and I'll be talking today about the effects of hospital volume on patient health gains. And this is a joint project with Niels Gutacker and Luigi Siciliani. Improving quality of care is an important policy objective in many healthcare systems, and hospital volumes are often seen as an important determinant of quality. And that is the case because high volumes of patients may lead to better quality through different mechanisms. So for instance, surgeons may become more proficient at treating patients if there's some sort of a learning by doing effect. Higher volume of patients may also lead to more effective and better team coordination, so cooperation and coordination between nursing staff and surgeons, or lead to better protocols of care. High volumes may also mean more cooperation with other healthcare providers, which are along the care pathway, or may justify more investment in better technical equipment. So if that is the case, if hospital volumes lead to better quality, then there might be a common policy option to try to concentrate the activity of care. And this can be done by implementing minimum volume thresholds, which will ensure that there's a certain minimum standards of quality of care. So there's quite a large evidence of a positive volume outcome correlation across different medical procedures. And this has been shown mostly in the medical literature. But the problem is that it's difficult to isolate the causal link that goes from volume to outcome from the potential reverse causality, which would go from outcome to volume. And so that is the case because high quality hospitals will also attract more patients in the first place, and thus result in higher volumes. And so this reputation effect would introduce some sort of reverse causality bias in the estimates of volume outcome association. And so this explains that to date, there's a relatively small causal literature that has tried to look at the effect of hospital volume on quality of care. So what we're trying to do here is to understand how hospital volume affects patients' health gains. So we focus on planned hip replacements in England. So hip replacement is quite a common procedure across OECD countries. It consists of replacing the damaged hip joint by an artificial one. We measure hospital volumes using the annual number of primary hip replacements which took place in a given hospital in a given year. And importantly, we measure quality or the success of the surgery using the patient-reported outcome measures, which are specific to the hip. And finally, the way we try to deal with this reputation effect is by predicting hospital volumes based on a set of patient and hospital characteristics, and most importantly, based on the patient's proximity to the hospital. To already give you a preview of the results, we find no causal effect of hospital volume on quality once we account for this endogeneity of volume. In terms of data set, we link two databases at the patient level. So we have hospital admission data, which is administrative records, which we extract for all planned hip surgeries, which took place in England in 2015 and 16. And we link those with the patient-reported outcome measures using patient ID. And this PROMS, patient-reported outcome measure database, consists of two questionnaires, the same, which were circulated just before the surgery and 6 months after the surgery. And this questionnaire asks a set of 12 questions, which try to assess the patient hip functional status and pain. And altogether, the answers to these 12 questions make the Oxford Hip Score, which ranges from 0, from the most severe possible health status, to 48 points, being the best possible health status. And so our data set consists of around 18,000 patients and 178 NHS hospitals. So this is just to give you an idea of what the Oxford Hip Score questionnaires look like. So for instance, the first question asks the patients, during the past 4 weeks, how would you describe the pain you usually had from your hip? And there are 5 possible answers, and each will be allocated a given number of points. In terms of methods, so now we use quite simply OLS equation to estimate the effect of hospital volumes on the post-surgery Oxford hip score. And in order to do that well, we need to control for potential differences in patient severity across hospitals. So we do that by including the pre-surgery Oxford hip score, as well as a number of clinical and socioeconomic traits of the patient. So we control for patient age, gender, ethnicity, socioeconomic status, the number of comorbidities, the patient's living arrangements, and the duration of the symptoms. And we also control for the exact type of hip replacement surgery. We also control for hospital status, because hospital status may influence health outcomes, but independently of volume. So in particular, we control for, we include a dummy for being a teaching or specialist orthopedic hospital. Finally, we also control for the characteristics of the area of the hospital. In particular, we include a control for the mean deprivation score, the average population age, and an indicator of the access to primary care in the hospital's catchment area. In the second step, what we do is we obtain the predicted hospital volumes. So these are the hospital volumes which we would observe in the absence of a sorting of patients, so in the absence of a reputation effect. And to do that, we obtain this by running a choice model, where basically the patients choose hospitals, mostly based on the distance to the hospital, and controlling for a set of patient and hospital characteristics. Okay, so this shows you the main table of results. So you can see in the first column here that we find this small positive correlation between hospital volume and outcome. So you see that patients who are treated in hospitals with less than 150 cases a year tend to report a lower post-surgery score, so Oxford hip score, by around 0.8 points. To put that into context and into perspective, this is quite a quantitatively small effect. And this is because this corresponds in terms of magnitude to around 20% of what is considered a clinically meaningful change in terms of Oxford hip scores. If you look at the second column now, we see that we find no effect, no statistically significant effect of hospital volumes on quality once we use the predicted volume. So once we account for this reputation effect. To interpret our results a bit further, we see that we find the volume outcome association that we find seems to be capturing a spurious positive relationship between outcome and volume. And this is driven by patients who saw themselves to select the good reputation hospitals. In other words, high quality hospitals also lead to higher volumes of patients. So to check the robustness of our results, we ran a range of robustness checks. So in particular, probably most importantly, we also controlled for individual surgeon effects by including surgeon volume and surgeon seniority. Our results are unchanged. In another robustness check, we also include a larger set of hospital controls, which may be endogenous to hospital quality, but we include them in a robustness check to ensure that we are correctly isolating the effect of hospital volume on quality from other potential confounders. So for instance, we also controlled for the hospital market competition, for the overall size of the hospital using the total number of beds, and by some measure of staff composition, among which the percentage of doctors who are senior doctors, and by the nurses to doctors ratio. So to conclude, in our setting, in this specific setting, we find no evidence of positive economies of scale in quality. So our results do not support further concentration of the provision of hip replacement in England on the basis or with the argument of positive scale economies in quality. And so more broadly, this topic has important policy implications for OECD countries in terms of the organization of the healthcare delivery. So understanding the causality and the mechanisms in the volume-outcome relationship is very important. So in the absence of true scale economies or learning by doing effect, concentrating care further may not improve health outcomes and may have potentially adverse effects, most notably in terms of reducing the access to care. Thank you very much.